you're going to talk about oral care, and we have the Dr. Marianne Coleman, who's another UK Australian, who's going to, from the University of Melbourne, who's a clinical vision research fellow, and Dia is a senior research fellow at the University of Portsmouth, and Marianne is from the University of Melbourne. Thank you very much both for joining me. Before we get into it, I'm going to play a very quick film to remind you as to why we're all here. It's coming into the last hour now. It'd be great to be able to announce a decent amount we've raised at the end of today. I know things are tight, but if you can make any donations you can, will be very gratefully received. You can go to chatathon.uk/donate or go to the Chatathon website. All the money you give will be divided between Alzheimer's Research UK, Alzheimer's Society, Race Against Dementia, and the Lewy Body Society, who all do amazing work in funding their research. Don't forget as well, we haven't had barely any this afternoon or this evening, but don't forget, if you have any questions, please do post them in the chat, and I will be sure to put them to Dia and Marianne over the next 25 minutes by the time this film's finished. So I'm going to play you a quick film now.
Think about this for a minute. The brain has masterminded everything we've ever known, everything we've ever discovered, ever created, every idea that's ever been, everything we've ever felt, ever seen, ever heard, ever said, or dreamt. So when it comes to Alzheimer's disease getting the better of our brains, well, you can't outsmart the smartest thing in the universe. Which is why the brightest minds behind Alzheimer's Research UK are making incredible breakthroughs.
Alzheimer's doesn't stand a chance. We can all use our brains to do something amazing. Simply share this film and spread the hope.
Powerful film from the Alzheimer's Research UK, who will receive 25% of everything you donate today. Thank you very much. Hello, dementia-friendly oral and eye care. Tell us everything we need to know, because this is going to come up, right? So many people who are listening at home will have loved ones who, these are things that get forgotten, aren't they? Do they get forgotten? Suddenly it's all about the dementia, it's about other things, and we forget to think about good eye care and dental care, which can contribute to other things. I'm preempting your entire sessions. Let's have some introductions. Hello, Marianne. Do you want to introduce yourself?
Yeah, absolutely. And it's a real pleasure to be back on Chatathon, having talked on linked topips last time.
There's no pressure, but you've got to have something new.
I do. And in fact, I have actually some lovely words from an Australian dementia advocate who I spoke with about my research proposal back in the beginning. She said that she felt that eye care was among the most vexed and unmet of physiological needs for people living with dementia. The other two being care of hearing and teeth. So I feel like it would be lovely to have a hearing person here with us today, but
we've
at least got 2 out of 3. 2 out of 3 ain't bad. My name's Marianne. I have a joint contract at the University of Melbourne, but also at the Australian College of Optometry here in Melbourne. So the College of Optometry provide eye care to people that would not otherwise be able to afford it, including visits to aged care homes and also older persons high risers, which we have a few of those in our state here in Australia. So as Adam said, I'm a clinical vision research fellow. I'm actually an orthoptist by clinical training. Dementia Pathfinders members may remember this.
What's the difference between an orthoptist, an ophthalmologist, and an optometrist?
Yeah, so you can even call me an optimist if you prefer. Orthoptist literally means straight eyes. So we are the people that specialize in diagnosing and treating problems with moving your eyes around and using them together as a pair. So we don't give out glasses to people and we don't do eye operations, but we work very closely with ophthalmologists and optometrists as part of the provision of eye care. And so I'm an orthoptist masquerading in an optometry research institution. Actually, the main research that I'm going to be talking about today is focused on optometry. So very multidisciplinary within that discipline of eye care.
We will come back to that. And Dia, why don't you introduce yourself? Is it Dia? Dia? Dia.
It is Dia.
Dia.
It is Dia. So my name is Dia Soilemezi, and as you said, I'm based at the University of Portsmouth at the Department of Psychology. So let me start by saying that I'm not a dentist. And the reason I'm here today is because for the last year and a half, I've been involved in a project who's looking at the dental oral care needs for people living with dementia at home. So my background is in psychology, and I've been involved in various projects as a health researcher. And this is the first time I've been involved in a social care type of research project, and it's very exciting. So I don't know if you were expecting some.
No. That's brilliant. And I mean, I touched on this at the start because I'm not wanting to steal your thunder, but my awareness of these particular issues kind of came up a few years ago, and they were really driven by, at that time, there was this push to kind of reduce our use of antipsychotic medication. This chemical kosh that was all too often being used in nursing homes and care homes. And when you drilled down as to why they were used, it was because people were becoming agitated. They were difficult to control. They were creating difficulties in their environments. And the alternative to using them was to look at fundamentally what's underlying the particular agitation. And I can't remember who did the talk, but I remember, watching these presentations at the time that highlighted the fact that, things like not being able to see properly and having tooth pain or having, dental pain or ear aches or being unable to hear people were often genuine things, because what happened was once people got a diagnosis, if they became hard, it became difficult to take them to the dentist or the optometrist. So those things started to be overlooked. They become a bigger issue if people can't communicate, which Anna talked about earlier. I'm sure Anna would be able to talk to us greatly about strategies for communicating and things. But that's where it became a problem. So it was brilliant when you both volunteered to come forward today, because I think this is an issue for lots of people. So Marianne, why don't you tell us about your work?
Well, quick shout out to Anna, because Anna is amazing and has done a whole bunch of fantastic articles on dementia research on a variety of different kind of topics. But yeah, I mean, we're all allied health professionals at the end of the day. We all kind of work together: speech pathology, audiology, orthoptics, and so on. So in terms of an overview of the issues, well, actually, hearing loss has been announced as being a modifiable risk factor for dementia. And actually, vision loss should have been in there as well, but it just kind of missed the boat, because at the time that all of the big researchers were doing that epic Lancet publication about modifiable risk factors for dementia, there wasn't quite enough information about vision at the time that they were doing that. But actually, since then, there has been a whole bunch of research that's been done, like epidemiological studies and things like that, that are showing if you can't see very well, it can actually increase your risk of cognitive decline. And basically, in the same manner as hearing, it can affect your social interactions. It can lead to you feeling lonely. It can limit your ability to participate in social activities. And actually, for the first time this year, the topic of sensory loss, so vision and hearing, was quite prominent in the World Alzheimer's Report. And so, the key point made there was about, seeing and hearing well to live well, like being able to see properly and hear properly helped people living with dementia to engage with other activities that are designed to promote their social well-being, and to try and, physical activity programs and things like that as well. You need to be able to see well and hear well to exercise safely, because these things can affect your balance and increase your falls risk. So yeah, basically vision didn't get much of a look in until recently. Yeah, and it's now becoming much more, people are much more aware of it.
I think that topic has moved on, as you say, when I first became about reducing agitation, but clearly this has moved on about the fact that poor eyesight or being unable to see or unable to hear has this knock-on effect, as you say as well, to contributing to social isolation, exclusion, withdrawal from society, from so not being able to participate in other things, which makes it so important, but also quite a challenging thing to address. So what does your research look at? I know in the past you talked about how you'd done guidance for how you can practically deliver eye care services to people living with dementia. Is that still something that you're looking at now? What's your work now?
That's basically what we've been doing for the last year and a bit. So basically, we started off by talking to lots of optometrists about their experiences of examining people living with dementia, because in terms of what people were doing currently, we didn't know that much. So as a quick kind of between country comparison, UK has actually dedicated guidelines about examining the eyes of people living with dementia. So the Royal College of Ophthalmologists has guidelines, and the College of Optometrists has guidelines, but in Australia there is nothing. There is no guidance at all. So basically, having sort of given that brief comparison, we are focusing on what we need to do to help optometrists to provide what we sort of call dementia-friendly eye care. And this was actually inspired by research that I did in the UK. So in the UK, I did some research that was looking at changes in eyesight and ability to judge distances over time. And we found that there was a decent chunk of people living with dementia that actually don't have great depth perception, which can increase your risk of falls. But as part of working with those people, because I saw them multiple times over a 1-year period, they were telling me their own experiences with eye care in a variety of different settings. So seeing the optometrist, seeing the ophthalmologist, and some of those experiences were not tailored to accommodate their dementia. So having to sit and do like a visual field test, they're like, look and click a button when you see a light, and if you're already having a little bit of difficulty with like fatigue and concentration and all the rest of it, but being expected to do that in an environment where there's people walking in and out of the room, and sometimes the lights get switched back on, and all this, that, and the other, it's not great. It's not great. And so that kind of prompted me to sort of think about this from, what can we do to make that experience better? How can we make it easier for people living with dementia to feel comfortable and confident in actually going to see an optometrist and knowing that their unique needs will be accommodated? So that's basically how this current research project came about. So we started off with interviewing optometrists about the experience from their end, but now we're interviewing people living with dementia and carers to find out about their experiences of interacting with optometrists, because once you get over the age of 70, you should be having an eye examination every year, right? So actually, for people living with dementia, it's especially important that they're keeping on top of their eye checks and so on. But if we can at least make sure that they're going to have the best experience possible when they go, then they're going to feel less kind of anxious and daunted about the idea of going. They might be less likely to have a upsetting experience or feel anxious or agitated when they're there in the appointment room. And if they feel comfortable, it's easier for the optometrist to test them. So there's a whole bunch of different reasons why it was useful to do this research. So we're doing a training course for optometrists from this research to help them feel more comfortable and confident about working with people living with dementia and carers. And we're also doing information about what to expect from the eye test for people living with dementia and carers, so that they have that understanding of what that means for them and why it's important.
And this is a great example, again, about encouraging these international collaborations, because as you say, if that already existed in the UK, I'm assuming it's not as simple as copying and pasting, because, different, worked in Australia too with University of Sydney, and I know that you can't just pick something up and drop it and expect it to work somewhere else. But it's a great start, right? Rather than picking up from scratch.
It's certainly better than nothing, that's for sure.
And just for the benefit of those that I remember this from last time. So the obvious one that people will go to, or the obvious thought on this, is that once people start to have language and communication difficulties, or their dementia progresses, you're not just going to say, well, you should stop bothering to do eye tests. How do you practically how do you then assess somebody's visual impairment when things start to progress worse?
Yeah, of course.
Progress worse. What terrible use of language was that?
You've been doing this for nearly 12 hours, Adam. Come on, give yourself a bit of slack.
How do you do that?
Yeah, so the research that we've done actually with optometrists today. So from the perspective of people living with dementia and carers, they don't necessarily see what the benefit is of actually letting the optometrist know that there's a diagnosis of dementia in the mix. And so actually the predominant experience from the optometrists that we interviewed is that they often don't actually know that the person has any form of cognitive impairment until they're sat down in the chair and they start doing the case history. So there is a lot of adaptation on the fly. There is no one size fits all approach, because once you've met one person with dementia, you've met one person with dementia. And so it's a very holistic approach. And so the optometrist is basically figuring out what to do and how to adapt their testing on the fly. They can look at their
eye tests from before and how things have progressed and deteriorated once they could communicate more. I understand that. I'm going to have to go to Dia now, because I've just suddenly noticed that it's already 10 to 9. Dia, tell us about your work. Does some of that resonate for you? Tell us about your work.
Yeah, absolutely. I mean, as Marianne said, having poor eyesight or poor oral care or hygiene can impact on so many aspects on someone's life. So I think I have to explain, it can affect their speech, their eating, drinking, obviously pain. I mean, it's one of the worst pains I've experienced in life, the dental pain. And obviously, people have, there's a lot of research that say that if people have poor oral hygiene, that can impact on their general health as well. So I guess our research started from the fact that we know that people living with dementia have higher risk of dental problems. And we specifically wanted to explore people who live at home, because my main research interest, if you like, is how we can help people live well. And the majority of people live at home. So let's see how they're managing. So the question we wanted to explore was how is the oral mouth teeth care addressed for those people living at home and having paid care coming in. So we interviewed home care agency staff, the carers that go in and support people living with dementia. We interviewed family members, and we interviewed social care practitioners. And as probably you already mentioned the word overlooked, and that's exactly what we have found, that although they all acknowledge that is such an important aspect of personal care, it can be missed, it can be overlooked, unfortunately. And there are various reasons why, the many challenges they face. And it could be related to, obviously, the person with dementia. They have some memory issues, forget to brush the teeth, even prompting sometimes doesn't work. It could be because they are not in mood to do oral care, they're kind of being asked to do different things, or they don't give consent to care. But it could be also things related to staff. So
in your research, have you kind of recruited a specific kind of group of people that are in receipt of, say, home care or living with family members or in nursing homes? Is that the stage? Have you already got beyond that, or is that the next stage? Is that the point and how do you then research there, I'm assuming that you don't go around and have a look in their mouth. You're talking about how often they do this and visit. How do you go about this?
So we obviously wanted to speak with people living with dementia, but it proved extremely difficult. So over a year that we had been recruited and various venues and liaising with various stakeholders, it hasn't been successful. So yes, I guess the people who still live at home and maybe independent, so they are able to do their own care, but they might need a bit of prompting from the carers coming in, or even people who are not able to do the task, either because they forget how to do it or for various reasons. So the carers then have to physically help them to look after the teeth and mouth. And I think I forgot your second question, Adam.
No, I was going to say, so having done that, then I'm assuming that you kind of, is the aim of this to then design an intervention or guidance or something you give to somebody to say, look, this is the problem. Here are some solutions we've come up with. This is the impact, if you like, of not doing that.
It must be a real burden for carers as well. In terms of actually having to take on all of those tasks to try and help that person as well.
Yeah, absolutely. I mean, and they have to prioritize. I mean, it's a sector that it's under great pressure at the moment. Shortage of carers, consistency of carers. The same people trying to go in to support the same people. So to answer your question, Adam, before I forget, yes, I mean, obviously we wanted to explore what's happening because there is research in care homes and there are guidelines about care homes, but nothing, at least that we could find, related to home care. And so obviously raising awareness and talking with the various people to understand, what actually are the practices. But the end of our project is, as you said, to come up with something useful, a guide or a checklist that home care staff, home care workers can kind of perhaps use it or not use it, but at least to prompt them. There needs to be discussion about oral care with the families at various stages, even at the initial assessment when either a social worker goes in or a care manager, home care manager, to kind of speak with them and plan the care, the support they need, to kind of raise those questions earlier on and see, if they need support, things like that.
And does that include, I mean, would you expect that would include, say, things like guidance onto practical strategies? Anna earlier will talk about strategies on how to kind of help people to communicate. Are there strategies to kind of how to encourage somebody to engage with oral hygiene, for example, or to do this who might not be so receptive? You could imagine that that we talk about this a lot. I'm so pleased that this has been looked at, because I think domiciliary care and care home professionals going into people's own homes to provide day-to-day domestic support and caring support is so under-researched. You come across so few pieces of research that inform the guidance around how those people work day in, day out. It's disbelieving how little that it is, that so often there's a little bit of on-the-job training. There'll be some MVQ, some other qualification as well, but ultimately then when you come into somebody's own home and that's somebody who says, no, I don't want to do brushing my teeth, they just go, okay, it's fine because I've only got 16 minutes anyway, or 8 minutes, and I've got to bath you, dress you, give you your breakfast, and then get out the door
and juggle dentures, hearing aids and spectacles.
So if you don't want to do that, I'm not going to make you. And then they work. And there's such a, and this is no disrespect, and if anybody's listening who works in that job, I'd love to hear how you get the guidance, how you get the training and support and the advice you need, and to be able to come up with strategies for this. So is that the kind of the aim, Dia, is to help those people?
Long term, but from what I understand, and as I said, I've done a dentist or a social worker, you don't need any qualification to become a carer. I think that you're doing an induction, some dementia training, and that's it. So some of the carers I spoke to, quite young, early, not a lot of experience, they didn't have the confidence to carry out those complex. I know it sounds silly, but it is a very personal task. You're putting something in someone else's mouth, so you have to make sure you have the consent. So they were very reluctant to carry on prompting. And as you said, they will leave the task.
And dental care let's face it, UK population's teeth and dental care it isn't exactly kind of held in high regard across the world. And the moment you go to the States, they kind of laugh at all of our terrible teeth in the UK. My teeth are terrible. But what's the role of kind of dentists in this? NHS dentist services, if you can, I don't know if it's cool like this year, there's always a controversy, you couldn't even find an NHS dentist, but if you did,
never mind a dementia-friendly one.
Yeah, exactly. So how do community dental services function? I mean, I assume that I know so little about this, I'm interested to know more. Are there community dental services that will then go out into people's own homes or into nursing homes and perform the things that they would have done had the person come to their
yes, they
surgery?
Is the answer. This a few things I'm learning during this project. So yes, there are, but they're not in every part of UK. And even if they are, they're not aware of them. So
the awareness is a big thing. Yeah,
they struggle to get access to dental treatment. So obviously, getting people there can be a very difficult task. Physically getting someone out of the house and driving there and things like that. So there are domiciliary dentists, and some of them obviously they have training on dementia, but it's not consistent. And I'm not aware if it's a long waiting list. But home care agencies, they were not all aware of them. They were struggling to find support. They would probably go to a GP rather than they might not even know which dentist. They're saying. So there is definitely some disconnection between home care, social services, and dental.
If you do,
same problem in eye care as well. The awareness of the fact that you can actually have an optometrist come to your home if you're not able to attend a high street practice unaccompanied is very low, and it continues to be low.
So this comes back to some of the people that could help resolve this. Clarissa Gleeble talks about this. She just discovered in Liverpool recently that covering the whole of the kind of Merseyside region were these 10 dementia care navigators, which didn't cover every region. They wasn't consistently applied. Not everybody knew about them. Same challenges. But they would, I guess, these people would be aware of these different services and where to get support. And I don't know if this is something that the Alzheimer's Society are involved in. I feel like if you're not, it should be. It'd be a great thing that if this isn't in your kind of post-diagnostic support package, making sure that there is an element in there. I don't know if you've ever looked at that, Marianne. I guess there's more likelihood you might have than anybody else, whether the Alzheimer's Society post-diagnostic support booklet covers things like oral care, eye care, ear care, and how even just highlights.
Reach out to me. I am happy to help get these bits of info into the right places.
They will come out. I'm sure
there has been talk previously about. There's been talk previously about a dementia eye care pathway in the UK. So there is a lot of stuff to suggest that this might be helpful. But actually, how that would shake down in practice and who needs to be involved in the design of it. People with dementia and carers, obviously, but also uniting all of those different eye care professions to actually develop something. Like we have guidelines, but we don't have a pathway per se.
I think we need you back in the
dovetail into that. So yeah, reach out to me. I'm on Twitter. I think Adam's already put all of my Twitter details up there. I'm really happy to share. And like it, in the same way as an eye care pathway, lots of other hearing care, dental care. Like really, once you get diagnosed, there should be a dedicated way that you can actually get onto those
I can't help but
really.
think that so we have this commitment from the government to double the amount of research funding in dementia, double the amount of research funding in dementia research. We have this commitment from the government to double the amount of dementia research funding, and I can't help but think that ears, eyes, oral hygiene. We talked earlier about hydration as well, and the importance of lighting on environments. All of these are kind of key areas that could definitely benefit from more research and more
and in the
funding.
home care setting, as you said, as well.
Exactly, not just in nursing homes. I think we've done a great deal. It'd be brilliant if over the next kind of decade we could see the amount of focus that's gone into nursing home research also be transferred onto domiciliary care as well, to provide that same level of focus and support to improve that. I think that's just a sector that's so stretched already. You know what, adding more research into that, more guidance to make sure that we're kind of, even if there is a limited amount of it, that what we are doing is the best possible care it can be, is got to be beneficial.
I cannot agree more. I cannot agree more, Adam, especially because dental diseases are preventable. So definitely more research on how we can make sure.
And I'm sure we've got Tamrin who's in the waiting room. I'm sure if we asked Tamrin about, she'd know best about this, I feel, about the links between gum disease. Gum disease has been connected to dementia as well in the past. And Marianne, I'm sure your problems for eyes will make it into the next modifiable risk factors update, which I'm sure must be on the horizon. Thank you so much, Dia Soilemezi and Dr. Marianne Coleman, for joining me over the last half an hour. It's incredible to have you here. Thank you so much. You can find out more about their work and their Twitter feeds as well in chatathon.uk, and the guests are at the top. Thank you so much. And do, if you have links to your projects you want to share or ways to get people involved, do post them in the chat or hashtag Chatathon, and I'll retweet those. Thank you.